At the end of this lecture, you should be able to explain how hemodynamic monitoring can help you identify and characterize a clinical problem. Firstly, is there a problem? And secondly, what is the problem? Describe the measurement and use of blood pressure and central venous pressure monitoring. Explain the role of pulse pressure variation and passive leg raising in hemodynamic monitoring. Before we start, spend a minute to think about the questions on this slide. The functions of monitoring are to detect if there is a problem, and if the answer is yes, then what is the problem? Monitoring should not be a substitute for clinical observations. Blood pressure monitoring may be used to supplement clinical signs to determine where there is a problem, and central venous pressure monitoring, pulse pressure variation, and passive leg raising may be used to supplement clinical signs to determine what is the problem. The function of the cardiovascular system is to deliver oxygen and nutrients to the cells and to carry away waste products. Ideally, we would like to monitor microcirculatory flow in all relevant tissue beds, but this is clearly not possible. As a result, we're left with monitoring blood pressure as a surrogate. However, we know that blood pressure is not a very sensitive guide to cardiovascular compromise, as there are compensatory mechanisms which are designed to maintain blood pressure. In other words, the patient may be shocked without hypotension. It is important, therefore, to look for signs of sympathetic stimulation, such as tachycardia, sweating, and vasoconstriction, and for signs of end organ dysfunction or tissue hypoxia. Automatic devices for monitoring blood pressure can be split into non-invasive devices and invasive measurements via an arterial line. Non-invasive devices tend to underread at high pressures and overread at low pressures. They also tend to be less accurate during arrhythmias and provide only interval rather than continuous monitoring. They are therefore less suitable for hemodynamically unstable patients. Selecting an appropriate cuff width is crucial to obtain the most accurate readings with a blood pressure cuff. The width should be 40% of the circumference of the arm. The advantages of invasive blood pressure monitoring using an arterial line are that this method provides continuous blood pressure monitoring, allows blood sampling, and if properly set up, is more accurate. It requires the insertion of an intra-arterial cannula. The system consists of an arterial line connected by saline-filled non-compressible tubing to a pressure transducer. This converts pressure waveforms into an electrical signal, which are displayed on the bedside monitor. The pressure is measured relative to the position of the transducer, which should be kept at the level of the heart. The transducer should also be connected to pressurized saline at 300 millimeters of mercury, which is also used to flush the line. The transducer is usually combined with an automatic flushing system, which flushes the line at the rate of 3 mL per hour. There are three major sources of error in invasive blood pressure monitoring. The system may not have been zeroed, the transducer may not be properly positioned, and the system may not be appropriately damped. The transducer should be kept at the level of the heart, in the mid-axillary line in the fourth intercostal space. If the position is too low, the system will overread. If it's too high, it will underread. Underdamping of the system leads to an overestimate of systolic pressure and an underestimate of diastolic pressure, while overdamping results in an underestimate of systolic pressure and an overestimate of diastolic pressure. The mean arterial pressure is the most accurate in both under and overdamped systems. Overdamping is commonly caused by partial occlusion of the arterial catheter or by an air bubble in the saline-filled tubing. The damping of the system can be formally tested, but is often simpler to check first for underdamping by determining the true systolic pressure with a simple test. Place a manual, not automated, blood pressure cuff on the limb in which the arterial line has been inserted. Inflate the cuff until the arterial trace is flat and then slowly deflate it until pulsation can just be detected on the arterial trace. The pressure displayed on the mercury manometer is the true systolic pressure. Invasive arterial pressure monitoring has a number of significant complications, including those listed here. Which pressure matters, systolic, diastolic, or mean? The pressure that matters most depends on the clinical situation. In patients with a high risk of bleeding, the systolic pressure is the most important. Diastolic pressure is a major determinant of left ventricular coronary blood flow and therefore is particularly important in patients with poor coronary blood flow, while mean arterial pressure is a major determinant of perfusion pressure of the other organs, including the right ventricle. Spend a minute to reflect on what you've learned so far. Think of 2 important learning points and why they are important. Central venous pressure is generally more useful in helping to determine the cause of a problem rather than detecting a problem. It measures right atrial pressure, which approximates to right ventricular end diastolic pressure. Ventricular preload, however, is more closely related to ventricular end diastolic volume than pressure, and it is therefore necessary to know the relationship between end diastolic pressure and end diastolic volume. This relationship depends on ventricular compliance. Thus, a patient with an end diastolic pressure of X and a normal ventricular compliance may have a high end diastolic volume and hence preload, while a patient with an end diastolic pressure of X and a low ventricular compliance will have a low preload. As the compliance is usually unknown and may vary with time in the same patient, a single reading of CVP is of limited use. By assessing the response to fluid, it is possible to get a better idea of end diastolic volume and hence preload. If there's little change in CVP following a fluid bolus, the end diastolic volume is likely to be low. If there's a big change, the volume is probably high. As a rule of thumb, if the difference between CVP measured before and 5 minutes after fluid bolus is 0 to 3 millimeters of mercury, the patient is probably underfilled. If it is 3 to 5, he's probably adequately filled, and if it's more than 5, he's probably overfilled. However, the response to fluid loading is not simply dependent on preload. In a patient with good ventricular contractility, increasing end diastolic volume may significantly increase cardiac output, while there may be a minimal change in a patient with poor contractility. For this reason, functional tests like passive leg raising may be more useful. In general, it is the left ventricular preload which is of greater interest than the right. The use of changes in CVP to give an estimate of preload is based on the assumption that changes in right ventricular preload correlate with changes in left ventricular preload. This assumption is not valid in many critically ill patients. For example, those with isolated left or right ventricular failure, valvular disease, or severe pulmonary disease. Nevertheless, there is considerable doubt whether the use of more invasive monitoring to obtain a better estimate of left ventricular preload, for example using a pulmonary artery catheter, results in better outcomes. Complications of central venous lines include pneumothorax, hemothorax, chylothorax for left-sided insertions, damage to the vein or adjacent structures, for example artery or nerve, venous thrombosis and thrombophlebitis, infection, guide wire or catheter embolization, cardiac arrhythmias, hemorrhage, and air embolism. Mechanical ventilation produces hemodynamic changes which are accentuated in hypovolemic patients. These changes are manifested as changes in pulse pressure, which is systolic pressure minus diastolic pressure, with different phases of ventilation. The magnitude of changes in pulse pressure can give a guide to the likelihood that the patient will respond to a fluid bolus. Pulse pressure variation is calculated by subtracting the minimum pulse pressure from the maximum pulse pressure, dividing by the mean of maximum and minimum, and then multiplying by 100 to obtain a percentage. In order to measure maximum and minimum pulse pressure, arterial tracing needs to be printed out unless pulse pressure variation is automatically calculated by the monitor. If the pulse pressure variation is more than 10 to 15%, the patient is likely to be fluid responsive. However, pulse pressure variation cannot be reliably used to assess likelihood of being fluid responsive if the patient is taking spontaneous breaths or is ventilated at a low tidal volume. If the patient has pulse pressure variation of less than 10 to 15% and a tidal volume of less than 10 mL per kilo predicted body weight, transiently increase the tidal volume to 10 mL per kilo to assess the pulse pressure variation. Pulse pressure variation also cannot be accurately assessed in patients with an irregular cardiac rhythm, as the variable stroke volume resulting from the irregular rhythm will result in a variable pulse pressure. Passive leg raising is another method for determining whether the patient is likely to be fluid responsive. It is like giving a reversible fluid bolus. If this results in a rise in pulse pressure of more than 10%, the patient is likely to be fluid responsive. Again, the patient needs to have a regular cardiac rhythm to make this assessment, but is not affected by tidal volume or spontaneous breathing. Write down 3 take-home messages from this lecture. I'll give you a minute to think about it. In summary, the question, is there a problem, can be answered using clinical monitoring and blood pressure, while what is the problem can be answered using clinical monitoring, CVP, pulse pressure variation, and passive leg raising. It is important to understand that central lines are associated with significant complications.